Hey, everybody, it's Dr. Eric Balcavage, and we're back for another edition of the Thyroid Answers podcast. And I can't tell you how excited I am today to have today's guest. I've been reading his work and his studies over the last, 10 plus years, I guess. And the work that you've been doing. And I have the deiodinase.org page as a little, on my page, so I can go back and reference things. But Dr. Bianco he's an MD, Ph.D. He's put a lot of time and effort into helping clinicians really start to change the conversation about how thyroid physiology works. So I reached out to him, and surprisingly, he reached back out and said, hey, he'd be more than happy to come on the podcast. So we have him today on the podcast to kind of talk about his book, Rethinking Hypothyroidism, that he wrote just recently. It's just recently been released, and to kind of talk about the frustrations from a patient perspective, but also maybe the clinician side of it, and why we need to kind of rethink hypothyroidism. Dr. Bianco, thanks so much for coming on the Thyroid Answers podcast.
Thanks very much for having me. It's a pleasure.
So I gave a little bit of an introduction, but maybe the best place to start is for you to kind of give some of your background for the listeners, because
Sure.
Typically what happens is some of the people that come to see us and listen to the podcast are frustrated. So they're like a medical doctor talking to us about thyroid stuff. They don't understand what I'm going through, but you have a different story. So give us your background.
Well, I am what's called a physician scientist, meaning, I see patients, but most of my time I spend running a research laboratory that's funded by the NIH. I was born in Brazil. I immigrated to this country 25 years ago. I spent about 10 years at the Brigham and Women's Hospital, Harvard Medical School. Then I went to Miami, University of Miami. I was head of the division of endocrinology. After a few years, I moved to Chicago, and I'm currently a professor of medicine at the University of Chicago, where I do studies. I have students, I have scientists working with me, and my focus has been to understand how thyroid hormone is regulated and how thyroid hormone acts in our body.
Yeah. So, and we in school, and even for a lot of the people who have been diagnosed with hypothyroidism, we kind of initially learned this really simplistic model, right? The thyroid gland makes thyroid hormone, T4 and some T3, and then it just goes into the system and it's magically converted. As long as you have enough T4 in the system, it's going to run the metabolism.
Right.
And if you get diagnosed with hypothyroidism and now there's not enough thyroid hormone in the system, then because the thyroid gland primarily makes T4, we just give enough T4 to normalize TSH into a certain range,
right,
and we call it a day.
That's right.
Right. So what's wrong with that model?
So there are a few things that punch some holes in that model, and by all means, that model has been well accepted for decades. So the first thing is that when you give someone, well, before we go into that, why does the thyroid exist? The thyroid exists to produce thyroid hormone. You just said it. The thyroid hormone what's the thyroid hormone produced by the thyroid gland? It's called T4, thyroxine, or T4 because it has 4 atoms of iodine. But T4 is not an active molecule. And I think that's a critical piece of information. T4 lacks biological activity. So T4 doesn't do anything. T4 does not resolve symptoms of hypothyroidism. In order for T4 to act, T4 must be converted to T3. So what is the biologically active thyroid hormone? T3. How do we know that? Because if we go into the cells of our body and we look for receptors is a key component of the signaling pathway for thyroid hormone. Who is sitting on those receptors? Is the T3 molecule, is not the T4. So I think that the number one thing we have to keep in mind is that T3 is the biologically active thyroid hormone. Now, the second thing is, how does the feedback work? And when is the thyroid and the feedback mechanism that regulates the thyroid is happy? Is when T4 is normal in the circulation, or is when T3 is normal in the circulation? And I think that that's a second piece of information that's critical. Our studies, let me just complete this thought. Our recent studies have shown that the thyroid system bends over backwards to keep T3 within the normal range. The focus of the regulation of the thyroid gland is not to keep T4 within the normal range. It is to keep T3 within the normal range. Well, you're saying that, give me an example. Okay, I'll give you an example. When you don't ingest sufficient iodine in your diet, what happens with your T4? Goes down, the TSH goes up, but how about T3? Is normal. Mm-hmm. So reacting to a problem, which is insufficient amount of iodine in your diet, how does the thyroid react to that? Okay, adjust TSH, adjust T4, but the T3 is normal. We have other studies in our lab in which we genetically modified mice. We knock out important components of the feedback mechanism, and every time we did that, what happened? T3 remained normal. So, and these are not only our studies, other laboratories have done and found the same thing. So the realization that the thyroid system exists to maintain a normal T3 level, I think for me, it's mind-boggling. I didn't think about that until about 10 years ago. I didn't realize that. And so that now we go back to your question. How do we treat patients with hypothyroidism? So the thyroid wants to keep T3 normal, but we don't even look at T3. We give T4 and we want to normalize TSH. That's all we want to do. But how about the T3? Never mind T3. I mean, it's not clinically relevant or whatever. I mean, there are a list of excuses, but the reality is we are not doing what the thyroid does all the time. A healthy thyroid functions to maintain a normal T3, and we don't do that when we treat patients with hypothyroidism with just levothyroxine.
Right, and that's probably the big crux of writing the book. And I think one of the other things is, when you're talking about, what is the thyroid, what are we looking at? Are we looking at T4? Are we looking at 3? Many times we're not even looking at either one of those, because often the screening test for somebody who's got hypothyroid signs and symptoms starts out with just a TSH.
Well, I mean, this is slightly different than what I said, right? You're talking about now diagnosis of hypothyroidism. And I think we need to make a big distinction. Mm-hmm. How do you make the diagnosis of hypothyroidism? That's one question. The second question is, how do you manage or do you follow a patient that has been diagnosed with hypothyroidism and it's currently being treated? These are two different scenarios, okay? Yeah. So the diagnosis of hypothyroidism, just to measure TSH is a little bit limited. I think that you do need to measure TSH plus T4 levels. I mean, usually people measure free T4 levels in the circulation, and that gives you a good sense of how the thyroid gland is working.
Okay. So before we get into that, because I want to talk about that aspect, the assessment and then treatment, I think we need to just kind of give patients a little bit of background on taking that simplistic model of T4, a little bit of T3 made by the thyroid gland, it gets into the bloodstream and it normalizes all the tissue. It's a bit more complex than that, but if we get to the next level, it's not just about how much thyroid T4 is put into the bloodstream. It's also a matter of what's happening at the cell level, right? Because there's control mechanisms at the cell. Most of the T4 or T3 production isn't made primarily by the thyroid gland. It's made by peripheral cells. Can you
Correct.
talk about what happened, what's primarily made at the thyroid gland, where's most of the T3 provided and made, and how is that regulated when we
Sure.
we'll talk about the deiodinase enzymes.
Right. So the thyroid makes T4 for all purposes. T4 only comes from the thyroid gland. And again, T4 is a prohormone. Now, the thyroid also makes a little bit of T3, but most T3, as you alluded, comes from outside of the thyroid gland. Where? Well, there are enzymes that convert T4 to T3 basically everywhere. I mean, there's, in the brain, there's a lot of these deiodinases, as they're called deiodinase because they remove an iodine. So deiodinase, removing one atom of iodine. So deiodinases are present in skeletal muscle, in the skin, in the brain, in the pituitary gland. I mean, basically, I can get a deiodinase activity from any tissue I want in the lab because I can change the sensitivity of my assay and I can measure T4 being converted to T3. So there's a lot of deiodinases, meaning that most T3 in the circulation does not come from the thyroid, comes from outside of the thyroid, T4 being converted to T3. Now, and that is that when back then in 1970, when doctors realized that just giving T4 to patients, levothyroxine, they will get a lot of T3 in the circulation. And they said, well, you know what? That's it. You just have to give T4 to patients. You don't have to give T4 and T3 because the body will produce a sufficient amount of T3 in the circulation. That was the interpretation. Now, T3 goes into the cells and acts. Some cells have deiodinases of their own, meaning they can produce their own thyroid hormone. And these are intracellular regulatory mechanisms, like, for example, the brain. The brain will make sure that there's enough thyroid hormone at any given time. And how does it do this? By adjusting the level of this deiodinase. So there's another deiodinase that inactivates thyroid hormone. So we have a deiodinase that activates thyroid hormone and a deiodinase that inactivates thyroid hormone. So deiodinases are really important in the thyroid hormone homeostasis. And some cells like a little bit more thyroid hormone, so they have this enzyme, this deiodinase that makes extra T3 for them. So they rely not only on the T3 that comes from the circulation, but also that's produced inside the cell. Other cells like less thyroid hormone. So they have the deiodinase, the type 3 deiodinase that chews up thyroid hormone. And then T3 is coming from the circulation and it can't get to the cell because the deiodinase will chop it up. So the level of thyroid hormone inside different tissues is different because of the action of the deiodinases.
And is it fair to say that the benefit of that is that allows each cell tissue system, each tissue, each system to be able to self-regulate independent of the other organs and systems so that we're not all systems are on at the same time?
Absolutely.
Because if it was, hey, I'm in danger, I need to activate my brain, I need to increase some T4, T3 so I can really get that sympathetic nervous system upregulated. Right. Yeah. I don't want my bowels in full digestive mode. I don't want all the systems the same.
Yeah, we call it a customization of thyroid hormone signaling. I'll give you two examples. One is the skeletal muscle. Mm-hmm. We put some mice on a treadmill in the lab, and we made them run for 20 minutes. After 20 minutes, the conversion of T4 to T3 is accelerated in the skeletal muscle, but it's not accelerated anywhere else. So in the muscle, because the mouse was running, that muscle is producing a little bit more T3 that has an important role in the metabolism of the skeletal muscle, but not everywhere else. Now, if I now take a mouse and put it in the cold, then in the brown adipose tissue, which is a specialized tissue that produces heat, the deiodinase will go up, but nowhere anywhere else in the body. So these deiodinases can actually allow the customization of thyroid hormone action. So the thyroid, again, produces that prohormone, T4, dumps it into the circulation, and the tissues have the ability to adjust and produce their own thyroid hormone. Now, the critical piece of information is you think, well, then that T3 that comes from the thyroid is really not important, right? You're just telling me that the deiodinases do the job. So why do we even care about that T3 that's coming from the thyroid? That is the thought that everybody had in the last 50 years. But the reality is that the T3, the little bit of T3 that's coming from the thyroid is really important, because if you treat someone that doesn't have a thyroid, now we're talking about a patient that was thyroidectomized, and you only give T4, you cannot normalize serum T3 levels and TSH at the same time. Once you normalize TSH, the T3 will either be in the lower range, very low range, or below the normal range. It will be at the end of the normal range or below the normal range, just because the deiodinases alone cannot maintain a normal level of T3 in the circulation. They need that little bit of T3 that comes from the thyroid.
So, and we'll get into that a little bit more, but I want to kind of summarize that for the listeners. T3 is so critically important because it's the primary driver of the hormones. And we can have a discussion about T4 and integrin receptors and maybe other actions of it. But for the simplicity of this discussion, T3 is what does all the work. But if you dumped just if the thyroid gland only made a whole bunch of T3 and we just dumped that out there, we'd have potential hyperreactivity and
right, you lose the ability to customize the thyroid hormone signaling. Right. I mean, if T3 is so important, why does the thyroid bother to make T4? Because T4 allows for the customization of thyroid hormone signaling. Right. But you still need a little bit of T3 from the thyroid.
And sometimes the way I explain to patients, it's like, why don't I always buy just pre-cooked food for dinner? Right? Why don't I just go to the grocery store and buy everything pre-cooked? Well, because it doesn't last as long if I have it that state. Maybe I have food and I can then hold on to it and then prepare it when I'm ready for, versus always having it. It's maybe a terrible analogy, but why not just have the thing I want immediately? Well, I want to make sure that stays preserved a little bit longer before I start to have bacteria growing on it or whatever. But that becomes really important. Now, we talked about deiodinase 2. That's the primary enzyme that takes that T4 into once the T4 comes into the cell, that's the enzyme that primarily converts T4 to T3.
Right.
You talked about deiodinase 3, which is the primary enzyme that deactivates T4 to reverse T3, but it also has another role. It can also deactivate T3, right?
It kills both T4 and T3,
which I think is something that gets lost sometimes even in the integrated model, because people think that if T3 is low and reverse T3 is high, I just give T3 and life is good. But they forget that the same enzyme that may be upregulated could still be deactivating some of that T3. But I'll get your opinion on that.
Okay.
But what's deiodinase 1? Because that was something that a lot of people think its primary role is the conversion of T4 to T3 as well. But what is deiodinase 1 and what do you see as its primary role and purpose?
Okay, so D1 was the first deiodinase that was discovered back in the 70s. When people realized that T4 could be converted to T3, D1 was what they were talking about. D1 is primarily located in the liver and in the kidney. And, maybe you have D1 somewhere else, but mostly in the liver and the kidney. And so everybody thought, well, this is the source of T3 from the circulation, liver and kidney. Now, then 10 years later, they realized that there was this type 2 deiodinase, or D2. And what happens is that D2 is T4 binds with much stronger affinity to D2 than it binds to D1, meaning that 1,000-fold more affinity. So it's not like a 50%, it's 1,000-fold greater. So D2 is 1,000-fold faster than D1. So yeah, D1 makes some T3 for the circulation, maybe 20%, but D2 makes the bulk of T3, 80%. And why is that? Because D1 has low affinity for T4. Now, why is it sitting there? What does it do? So we believe D1 does not have affinity, very low affinity for T4 and T3. However, when T4 and T3 are modified by the liver, like I'll give you an example, T3 can be sulfated. So when a group of sulfate is attached to the molecule of T3, then it binds with high affinity to D1. So what happens? T3 sulfate is eliminated in the bile through the liver because it becomes soluble in water. So it can be eliminated through the bile. And D1 apparently wants to rescue the iodine, doesn't want to lose the iodine to the bile. And so T3 sulfate is rapidly deiodinated in the liver and T4 as well in order to preserve iodine. So the rest goes, but the iodine stays. So D1's role seemed to be in this scavenger role for protecting the iodine homeostasis, not letting thyroid hormone metabolites that are iodinated go into the bile or go into the urine, because D1 is also present in the kidney. So in order not to preserve iodine homeostasis, and not so much in terms of producing T3 for the circulation. Maybe 20% of the T3 in the circulation comes from D1.
So it kind of, when I was in school, one of the things we were taught, like, hey, most of the T3 in circulation comes from D1, and now we've seen that that's not necessarily the case.
Right.
Deiodinase 3's role is really deiodinase 1's role is primarily like, how do I get some of this iodine stuff back, because it's so important for the system.
Yes.
There's also something called reverse T3 in the system, and that's the deactivated form of T4. What is deiodinase 1's role in that? What's its process with reverse T3? Because that gets a lot of discussion in functional medicine.
Right. D1 can do internal ring deiodination of T4. So some reverse T3 could potentially be involved in there. However, the greater role of D1 is to clear reverse T3 from the circulation. So once the reverse T3 is produced, and reverse T3 is produced basically by the type 3 deiodinase, where does reverse T3 go? It has to be cleared from the circulation. And the clearance of the circulation comes from D1. So if you have high reverse T3 in the circulation, why is that? So that's a question that we both need to discuss. Why would someone have high reverse T3 levels in the circulation? So at first, back in the 70s, people realized, oh, wait a minute, there's some situations in which reverse T3 is up. Mm-hmm. What are those situations? In gravely ill patients that are in the hospital, they're admitted to the hospital, it's life-threatening diseases. Reverse T3 goes up, and T3 goes down. So the interpretation at that time was that, oh, wait a minute, the thyroid produces T4, and instead of now being converted to T3, the T4 is being converted to reverse T3, and T3 levels go down, and reverse T3 goes up. That was the first interpretation. Then it rapidly became clear that reverse T3 was up because it wasn't sufficiently clear from the circulation, because D1 wasn't doing a good job. So D1 that has to clear reverse T3 is low. There's low activity of D1 in this gravely ill patients, and reverse T3 was accumulated in the circulation. Now, later, probably 10 or 15 years later, some other researchers found out that indeed the type 3 deiodinase, D3, is upregulated in these severely ill patients. So it's a combination. You have accelerated D3 activity. You're making more reverse D3, decelerated D1 activity. So you're not clearing reverse D3 from the circulation. And then as a result, you have high levels of reverse T3 and low levels of T3.
And I've read some study, we hear about the critical illness, but I've read a bunch of papers that say just chronic illness and chronic inflammation in the system can do the same thing.
If it's intense enough, we'll do the same thing. Yeah, I agree.
So, and then so why else might T4 be elevated? Could reverse T3 be elevated? Could it be elevated because of too much thyroid hormone medication?
Well, so that's a loaded question. If you're treating someone with levothyroxine, you're going to reverse T3 will be in the circulation. Now, the more T4 you have, the more reverse T3 you're going to have, because T4 is the only source of reverse T3.
Right.
Therefore, if you're giving someone a small dose of levothyroxine, your reverse T3 is low. As you increase the dose of T4, the levels of reverse T3 are going to go up. So there's a correlation between T4 and the reverse T3. It's just because T4 is the source of reverse T3.
Right. So I want to jump back with the deiodinases. In deiodinase 1, do we know what's down-regulating deiodinase 1 activity in chronic or critical illness? Is it inflammation that down-regulates it, or inflammatory cytokine that's down-regulating it? Is it hypoxia? Do we know?
I think that what we know for sure is that carbohydrates in the diet can, if you remove carbohydrates from the diet, you're going to down-regulate your D1 activity. That has been studied both in rats and humans, and that's pretty clear what happens. So if you lower your food intake and especially the carbohydrate content of your diet, you're going to lower D1 activity. Just because the liver, I think, is like the center of all this food that's coming into the body. So if you don't have a lot of food coming into the body, your D1 activity, which is in the liver primarily, it's going to go down. Now, you mentioned a lot of other things, cytokines, and I don't think hypoxia affects D1, but cytokines might very well affect. Maybe there are some studies showing that cytokines could affect D1. I'm not totally familiar with that, but it is a possibility.
So do we see let's say we had a hyperthyroid state, do we see an increased activity of deiodinase 1, and do we see it shift its primary ligand from reverse T3 to T4?
No. The affinity of the enzyme is always the same for this substrate. It's not going to change. What happens is that D1 is induced by thyroid hormone. So the more thyroid hormone you have, D1 keeps going up, 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 up. It's a positive feedback, okay? T4 gets converted to T3, and T3 stimulates D1 to convert more T4 to T3. So in an individual that has a normal thyroid function, most T3 comes from the D2 pathway. 20% comes from D1 only. As you have more thyroid hormone and more thyroid hormone, you become hyperthyroid.
Right.
There's a switch. The D2 role goes down and the D1 role goes up. So in a hyperthyroid patient, the role, where is T3 coming in from the circulation? Where is it coming from? Well, it's coming from the thyroid, but it's mostly coming from the type 1 deiodinase. The role of D1 gains predominance just because the thyroid hormone accelerates D1 activity. So you have much more D1 than you would otherwise have in a normal person.
And is it possible, and I don't, this is just my thought process is typically, and we'll talk about it, like more T4 causes the ubiquitination of deiodinase 2, which is, for the listener, that means it turns off the enzyme that converts T4 to T3.
Correct.
And I'm going to let Dr. Bianco explain why that is important from a health standpoint. But because that mechanism's there, my thought process is the reason we ramp up, that makes sense for deiodinase 1 to ramp up, is I've got all this thyroid hormone in the system if I'm hyperthyroid, and the half-life of T4 is what? It's closer to 7 days, 8 days, something days. The half-life of T3 is what? 12 to 24 hours, somewhere in that range.
12 to 24.
And if I have this, and T4, and we can have that discussion later, from what I've read, has an impact on the integrin receptors on the plasma membrane. So if I have all this excessive T4 into the system, and it's got a half-life of 7 to 8 days, if I convert this stuff to T3, that's got a half-life of 12 to 24 days, that's a way, given that one enzyme that converts T4 to T3 is downregulated, this one can at least continue that conversion and get it out of the system faster. Maybe it's a flawed thought process, but that's how I kind of see why it might make a lot of sense for deiodinase 1 output or to increase.
Yeah, it's hard for us to well, I didn't design the system, so I don't know why things work the way they work. I think it's much more logical to understand the D2 regulation than the D1 regulation. I think D1 is a little bit of a mystery. Why would it be sensitive to T3? Another interpretation is that if it does have a scavenger role, the more thyroid hormone you have in the system, the more you have to play that scavenger role. So, you're creeping up because you have to rescue more iodine. I mean, I think that it's, we don't know why things are. I mean, that's why I like to focus on what really is happening, and the interpretation it could be open to a lot of things.
Yeah, it's definitely open to things. It's just but those are the ideas. I'm sure that all those, as people start saying, well, wonder why this is, I wonder why this, those ideas and thoughts and questions and hypotheses are the things that lead to studies that help us understand a little bit more about what's going on.
So you touched, when we were talking, you touched about T4 acting with integrins. And I think that's an important point that you mentioned. So that means T4 could have a mechanism of action, could have actually a biological effect, independent from thyroid hormone receptors, because we know it doesn't bind to thyroid hormone receptors. Now, it's called non-canonical pathway of T4 action. That has been shown to occur at very high levels of T4. So the problem it's not a problem. The caveat with this thing, which is real. I mean, I granted, if you put enough T4 in cells, you're going to activate that pathway. But how much T4 do you need to activate that pathway? You really need a lot of T4. So it's much more of a pharmacological effect that requires maybe 2 or 3 orders of magnitude more T4 than you will ever have in your blood. So you can make that happen in cells, but is that happening in our body at that moment? It's probably not. I think that there's one paper more recently, one paper in which the scientists, they knock out some of the T3 receptors, and they still had some effects of T4. So, and I think that's nice, but that's one study that needs to be reproduced, that needs to be further evaluated. Most of this integrin story is a story that is associated with very high levels of T4.
Okay. Yeah, I'll have to take a look. I'll go back and take a look at some of those studies that I've read, but I don't know. I don't recall how much they thought was in the system, but I think it's worth having taking another look at it and
just think about it, because the physiological level of T4 is 10 picomolar.
Mm-hmm.
So 10 picomolar is a very low level. And the same level for T3 is also 10 picomolar. So the amount, if you're the receptor, how much T3 and T4 are you looking at all the time? You're looking at 10 picomolar T3, 10 picomolar T4, and the receptor has 10 to 15 times more affinity for T3 than for T4. So it's always, because they're both in similar concentrations, T3 is always going to be preferred by the receptor. Now, for the integrin, you need nanomolar, sometimes micromolar level of T4, which is, you're not going to have that.
Okay. I'll revisit that, and then maybe
sure.
that's another conversation.
Yeah.
So,
Sure.
so then let's talk about what's going on when we're assessing somebody. We've kind of talked about, we've got thyroid hormone that's T4 primarily generated by the gland. It gets into the body proper, gets to the cells. Cells can convert and regulate the amount of T3 inside the cell. That T3 comes back out of the cell and becomes part of the circulating levels of T3, so that T3 can go support other tissues, right? And before it finally gets metabolized and cleared from the body. So when we look at thyroid physiology and we're trying to assess why somebody might have hypothyroid signs and symptoms, is it possible they could have those hypothyroid signs and symptoms but still have a normal TSH, a normal T4? And what about a T3? Even though it's not often measured in traditional allopathic medicine, could they still have hypothyroid signs and symptoms despite having normal TSH? Let's start normal TSH, make it easy.
Okay, so let's talk about this. Hypothyroidism is when the thyroid is not working well, or the thyroid is just not there, right? Mm-hmm. So you can be born with hypothyroidism, then it's a genetic condition that your thyroid doesn't work well. That's one thing. This is actually not that rare. But we are talking about adults that have lived a normal life until a certain age, and then they become hypothyroid, or they might have become hypothyroid. How do we know that? So it means the thyroid was working well, and then the thyroid starts to not work so well. So that means that the production of thyroid hormones has to decrease, right? Because the thyroid, if the thyroid is not working well, what's going to happen is that the output, the thyroid output is going to come down. And the thyroid makes mostly T4. So if you want to know if the thyroid is working well or not, you're going to measure T4. Why we don't measure T3 to make the diagnosis of hypothyroidism? Because the body bends over backwards to keep a normal T3. We talked about it. T3 is the last thing that is going to go abnormal. If you follow someone that had a thyroid surgically removed, after the thyroid is removed, T4 starts to go down very fast because it's no longer being produced. TSH starts to go up very fast, but T3 holds there. T3 is there for a few days. Why? The deiodinases are changing the way they work, and T3 can be maintained. So from a diagnostic point of view, T3 is not a great tool. You're going to focus on T4, free T4, and TSH. Now, you asked me, is it possible that someone has hypothyroidism despite a normal serum TSH? So you have to assume that something has changed. Otherwise, it will have to be a genetic condition, right? If you say, well, someone lacks a thyroid hormone receptor. Let's say if you lack a receptor that's called TR-alpha, thyroid hormone receptor alpha, you might have a normal TSH, and you might have hypothyroidism in some parts of your body. but that's a genetic condition. This is going to be detected since you were born or since childhood or adolescence. It's not going to happen when you're 40 years old. Now, to think that when you're 40 years old, you have a normal TSH and you have hypothyroidism, something must have happened. Okay, what could be? The most obvious thing, it's something that's called central hypothyroidism. Okay, your hypothalamus is a problem, your pituitary gland has a problem, and it's the feedback mechanism is no longer working. This could be caused by a tumor that's growing in the hypothalamus or a tumor that's growing in the pituitary gland. Yes, that could cause that. Some drugs can cause that. Retinoic acid can cause that, can mess up with the TSH regulation so that there's a disconnect between thyroid hormone levels and the TSH. Some new drugs that are used in the cancer treatment might affect how the pituitary gland works and cause the pituitary gland not work very well. So then there are a series of conditions in which there's a disconnect. The TSH is not reliable anymore as an index of thyroid gland function. But most of the time, if you consider, is there a tumor? Is there a disease? Is there a drug, meaning another type of drug that is affecting the TSH regulation? If you exclude all that, it's hard to imagine that you have a patient that has hypothyroidism, meaning the thyroid is not working well, and you still have a normal TSH. What did you have in mind?
So when we're talking about hypothyroidism, like if somebody's got, we're talking about a gland, could the gland be working? No disease of the gland.
Okay.
The person has hypothyroid signs and symptoms. They show up, get a TSH done with a reflex to T4. Their TSH is normal or low, but they still have hypothyroid signs and symptoms. Is that possible?
How about the T4?
We don't even know because it's a
okay.
it's a TSH with reflex to T4, right? So if it's TSH is normal.
If that person has hypothyroidism, has to be a condition called central hypothyroid or secondary hypothyroidism. Now, is there a way that the tissues become insensitive to thyroid hormone? That you still have normal levels of thyroid hormone, but those tissues don't respond anymore? I don't know. Unless it's a genetic thing that the person was born with that condition, I don't know other situation that could be caused. When you say signs and symptoms of hypothyroidism, you have to keep in mind that those signs and symptoms are very non-specific.
Mm-hmm.
So, for example, I feel cold all the time. Mm-hmm. Well, you don't have to be hypothyroid to feel cold all the time. My skin is dry. My hair is falling. So there are other diseases that can cause these symptoms as well. So they're not what's called pathognomonic of hypothyroidism, meaning that they're not, it's not something that, oh, there you go, you have hypothyroidism. You know what I mean? The only thing we have that can point to a hypothyroidism is the TSH level being elevated or T4 levels being below normal.
So there's discussion in the literature, it's probably 20, maybe 30 years of tissue hypothyroidism, right?
Sure.
Reduced. So are you thinking that that doesn't happen unless the thyroid gland is dysfunctional?
Well, tissue hypothyroidism, give me an example, for example, and then I'm blanking on this. Give me an example and we can talk about it.
So could somebody have a normal TSH, right? But but you might see they've got signs and they have symptoms and they may have elevated let's say they have elevated cholesterol, LDL, maybe they've got elevated triglycerides and VLDL, which could be, and there's other factors. That's why we have to assess more than just one or two
Sure.
markers. But the elevated cholesterol and LDL could be markers of T3 deficiency. The elevated triglycerides and VLDL could be an indication of compromised T3 levels.
They're
right?
all markers of T3 deficiency. That's correct.
So I think what happens, and the reason I'm kind of asking this is because what happens is for a lot of people, they have hypothyroid signs and symptoms, and primarily the symptoms, right? I'm overweight, and my hair's thinning, my skin's not good, and they go to a physician, and they get the standard might be a TSH with a reflex to free T4, and TSH is normal, and their doctor says, hey, you don't have a thyroid condition because the TSH is normal, but there are factors, at least based on the literature, that seems to show that there are other things that could drive TSH down, at least in the short run, and potentially hide a thyroid issue if we're only looking at TSH. And maybe not potentially early on hide a gland issue, but primarily just not consider that what's going on at the tissue level is normal because of TSH.
Right.
Are there stress factors that could cause an increased conversion of T4 to T3 at the hypothalamus? Is there inflammation? How does inflammation impact the conversion of T4 to T3 at the pituitary of the hypothalamus?
No, but that is, we're in agreement. I mean, I would just put that in the bucket, what's called secondary hypothyroidism.
Mm-hmm.
So you're disrupting the feedback mechanism. I mean, and we know that tumors do that. We know that certain drugs do that. And maybe there are physiological situations that you can do. I'll give you an example. Fasting. Fasting is an example, a typical example in which the thyroid will shut down. If you reduce your caloric intake dramatically, what happens is that your levels of T3 and T4 start to go down. The TSH doesn't go up. Mm-hmm. You're disrupting that feedback, showing that there are physiological mechanisms that can, in fact, switch the way the feedback works and disrupt that relationship. So it's a good question. If a person is fasting or reduced caloric intake, the levels of thyroid hormone in the circulation are low, the TSH is not going up, does that person have hypothyroidism in the tissues? That's a very good question. And I would say we don't have a good answer for that because what we know is these patients don't have a lot of symptoms of hypothyroidism. Maybe there's some adaptation at the tissue level, but I think it's a question that is being investigated in different labs. Now, you mentioned lipids, cholesterol, and let's just make sure we're talking about the same condition. You're talking about a patient that has a questionable diagnosis of hypothyroidism, not someone that has been diagnosed and being treated. No, we're talking about someone that we don't know if has hypothyroidism and comes up with the normal TSH and lipids all over the place, very high.
Yeah.
Can that be a sign of liver hypothyroidism? I would tend to think that no. There are 300 different causes for why people have dyslipidemia, have high lipid levels in the circulation. Now, I always keep an open mind. I've been wrong. I was very dogmatic when I started this thing. And if you read my book, you will see how I was wrong so many times. So I keep in mind, a really open mind about this. We know, for example, that if you have liver steatosis, which is a lot of fat in the liver, that liver is relatively hypothyroid. We know that.
Right.
Which the liver does not, even though thyroid hormone levels in the circulation are normal, but the fact that the liver has steatosis makes it reduces thyroid hormone signaling. We've studied that, other labs have studied that, so much so that there are pharmaceutical companies developing a T3 molecule that goes straight to the liver
Yeah.
to fix the problem of liver steatosis. So I think that would be a good example of what you're just asking, a disconnect, an isolated situation of reduced thyroid hormone signaling in an otherwise healthy person that has a normal TSH, normal T4, T3 in circulation.
Yeah. So, and the reason I say that is because a lot of times people, and it's, doctors are trained and the guidelines are such a way that, hey, this is what we do. And so in a functional medicine world where I live, I typically look at broader labs. I don't look at just a thyroid panel. I look at a thyroid panel in contacts with inflammatory markers. I look at thyroid panel in contacts with my lipids and my cholesterol markers. I look at it in contacts with my blood sugar markers. So if I have a low T3 on somebody and they have hypothyroid signs and symptoms, it doesn't necessarily mean they have an issue. We have to take everything in context, right?
I agree. Patients are complex. Patients are not animals that we experiment in the lab. Patients are complex individuals.
So we might,
and even if you ask me the steatosis thing, we just learned recently. So if you had asked me 10 years ago, is there any issues with liver hypothyroidism? I'll say, of course not. But now we know better. We know that, yes, indeed, the T3 action in the liver is reduced when you have steatosis.
Yeah. So I want to get into some of the more of the stuff that's really kind of the sweet stuff that you talk about in the book. And that is maybe some of the challenges with what is commonly done in allopathic medicine when somebody is diagnosed with hypothyroidism, and you said, hey, for good reason, TSH becomes a really important test to determine, hey, this is when the glands can no longer keep up with it.
Right.
But what's your perspective on why somebody, as they go on thyroid medication, typically one of the things that physicians are kind of taught to do is try and create biochemical well-being, meaning if I bring that TSH within a certain range, life is good. How did you come to the conclusion that maybe this isn't where it doesn't create physiologic well-being versus biochemical well-being, right?
That's
and
exactly
where the problem occurs.
Yeah, and I think that's exactly that. You brought us back to your first comment. The thyroid system is the quintessential example of feedback mechanism. I mean, I learned this thing in first year medical school. This is how you treat patients with hypothyroidism. You just give T4, you normalize TSH, and everything is fine. And we learned also from our guidelines that if you have a normal TSH, you're euthyroid. You should have no more symptoms. I mean, that's it. Your symptoms of hypothyroidism are gone because your TSH is normal. So why that's not the way it works. So what happens is when we give someone levothyroxine or T4, T4 doesn't suppress TSH. T4 needs to be converted to T3 in order to slow down TSH production, to activate the feedback. So in your brain, in the hypothalamus and the pituitary gland, T4, we're treating someone with T4, and T4 is being converted rapidly to T3 in the brain and slowing down TSH production. At the same time, in the rest of your body, T4 is being converted to T3 to activate, to just normalize T3 in the circulation. So you have two processes. One is the central process, which is involved with the TSH regulation, and the peripheral process that's involved with T3 for the rest of the body. Remember, the only source of T3 in these patients, in a hypothyroid patient, is the tablet of T4 that you're giving, because it needs to be converted. So you would imagine that these two processes were coupled to each other. You'd think, well, yes, because D2 is key for both processes, right? D2 is in the brain, converting T4 to T3, slowing down TSH production, and D2 is in the periphery, producing T3 for the circulation. It's the same enzyme. meaning that I give T4, I normalize TSH, and of course I am normalizing T3 levels in the circulation. Bang, wrong. That's not how it works. T3, when you normalize TSH, T3 in the circulation still has not been normalized. You have a relative excess of T4 and a relative deficiency of T3. In some patients, T3 levels are even below the normal reference range. Mm-hmm. Why is that? Because there's a protective mechanism. The periphery downregulates T2. The more T4 you give, the less T3 you produce. This is to protect ourselves from an excess of T3. So if you're taking tablets of T4, the periphery is absorbing all of that, and the more T4 you take, the less T3, relatively speaking, you're going to make. Mm-hmm. The pituitary gland doesn't work like that. The more T4 you give, the more T3 you produce. So the T4 is really good at suppressing TSH. It's phenomenal because you increase a little bit of T4, TSH goes down. So there's a very intimate relationship between T4 and TSH. The periphery, that's not how it works. You increase T4, T3 holds. T3 doesn't go up because you're losing deiodinase too. Therefore, why did we, if this is so obvious, why we didn't realize that before? Because we don't measure T3. We just measure TSH and free T4. But did we just started measuring T3 now? No. 1974 is the first paper showing that patients treated with levothyroxine have a relative deficiency of T3. This was published in the New England Journal of Medicine, a prestigious journal. So I would think, oh, gee, we're giving T4 to these patients, and T3, we have a relative deficiency of T3. You know, a red flag should have said, well, wait a minute, let's rethink about this. Are these guys really, are we normalizing thyroid hormone signaling everywhere? No, we're just normalizing TSH. I would have thought that people would have stopped. No, they kept going. They forgot about it. There were some other papers that published that T3, in fact, was low or relatively low. And the guidelines never talked about it. The guidelines always talked about normalizing TSH, normalizing free T4, and it was sort of a polemic thing, maybe a controversial thing, let's put it that way. I don't remember ever going to a meeting and people talking about low T3 in patients with hypothyroid with normal TSH. I don't. Until recent, maybe 10, 15 years ago, there was a paper, an Italian paper, in which the doctor, he looked at 2,000 patients that had hypothyroidism and were treated with levothyroxine. And he showed black and white that T3 levels are relatively low. And in 15% of the patients, they're below the normal reference range. So that now the last ATA guidelines for treatment of hypothyroidism, it says some patients might not normalize T3 in the circulation. And that is a big deal. Why? Because T3 is the molecule that acts. So if you have if you're normalizing TSH, but you're keeping a low T3, are you kidding? This is, why are we doing this? Why are we not trying to normalize T3 in the circulation?
Yeah, and a big part of it is what gets measured gets managed. So if you don't measure it, the problem doesn't exist,
exactly.
right?
Exactly. That's no. It come to a point with me in my office that if the patient said, "Oh, doctor, should I measure T3? Should we measure T3?" I said, "No, forget about it," because I know that the T3 is going to be relatively low, and measuring T3, then I didn't know what to do, because then I have to start that patient on T3. Because you know, if you take your car to the shop and you say, "Well, can you take a look here?" I don't want to take a look. No, but please take a look here. Oh, there's a problem. So what do you do? You have to fix that problem, right? If you identify a problem with your car, you have to fix the problem. You're not going to go driving around with a problem. is the same thing. The minute you detect a low T3, you have to do something about it. And what do? As doctors, we don't know. We don't have guidance because we have not focused on that before. So it's not that we don't have a guidance say, oh, if you find T3 low, you have to start patients on T3. No, this is common sense, but we don't say that. We don't write that. We don't teach that. Common sense says if T3 is below normal, oh, wait a minute, there's got to be something wrong here, right? And that is the conundrum here of this treatment of hypothyroidism. We've been focusing on something that gives us peace of mind, meaning, oh yeah, I normalized TSH. I'm happy. I did a great job with this patient because the TSH is normal. The free T4 is there's a lot of T4 there. And that's it. I don't measure T3. Now the patient come and said, but doctor, I still don't feel perfect. My cholesterol could be higher. Mm-hmm. I gained some weight. I mean, I can't put off this weight. And I used to tell my patients, there's nothing to do with the thyroid. Your TSH is normal. Mm-hmm. Until I start digging into this and realize that low T3 has some significance. The energy expenditure is slower in these patients, which is what you would expect. If you have a low T3, you would expect to have a lower energy expenditure. Mm-hmm. Lipids are higher, as you mentioned. Mm-hmm. Yes. What would you expect to have from a low T3? Yeah, I would expect to have a high cholesterol, and they do. Mm-hmm. And keep in mind that a hypothyroid patient on levothyroxine is twice more likely to be on statin medication. So they are on statin more than other individuals that don't have matched same age, some sex, but they're twice as more frequently on statin, and still they have a higher cholesterol level in the circulation. So they weigh more. We did an enhanced analysis, and we saw that patients on levothyroxine with a normal TSH, they weigh 10 pounds more compared with matched patients with matched controls. So they weigh more, they have a slower energy expenditure, and they have high cholesterol. Are you going to tell me that they don't have a T3, insufficient levels of T3 in the circulation? I think that's pretty obvious. But, in medicine, I'm talking to you in a conversation, but for us to write this down, we would need to have a clinical trial showing this. And this is evidence-based medicine, right? I mean, we need to prove these things. Right now, we have a lot of, circumstantial evidence, which is very compelling. But it's, we still have to do the trials.
Right.
And they can be done. The problem is to do a trial like this, you need to enroll a few hundred patients. It costs
millions.
Between $10 and $20 million.
Yep.
Who's going to pay for it?
Yeah, probably not the company that's making T4, right?
Well, no, I mean, the company that makes T4, the company will do everything that the FDA asks them to do. Okay. So the T4 is approved. Nothing is going to happen with T4. But the interesting thing is that what's happening these days is that the companies that make desiccated thyroid extract, desiccated thyroid extract has never been formally approved by the FDA. So the FDA started a few years ago a movement to, if they wanted to continue in the market, they will have to get a full approval. So to get a full approval, you have to do these clinical trials. And I think that's a good thing that's happening, because everyone that has a desiccated thyroid extract product in the market is being forced by the FDA to do these clinical trials that are needed to show effectiveness and to show safety.
Right.
And in the effectiveness piece is where you can look at this stuff that we're talking about: body weight, cholesterol, and statin, other medications. You can look at quality of life. So in a way, the fact that they want to continue in the market and the FDA is making this request, it's a good thing for science and for patients because the clinical trials are being done.
So one of the challenges, I think, once somebody gets diagnosed and they get put on thyroid medication, is many times that TSH number is being driven to a certain preconceived idea of what it should be. Some people think it should be under 1. Some people think between 1 and 2. Some people less than 4. Like, what's the is your opinion that we shouldn't be trying to treat a TSH, or we should keep the TSH? And every case is a little different, but people are always looking for what's the range I should be in for TSH. Right. And in looking at things, and especially starting to see that maybe a higher TSH helps with the compensation for T3. If I supersaturate with T4 and I suppress TSH too much, do I lose the thyroid gland's ability to help compensate for the reduced peripheral conversion?
Or the ones that have a residual thyroid gland, yes.
Right. So if they still have physiology left, like is there a set value that we should say, hey, this person still has a thyroid gland, and we don't want to suppress TSH too low, because if there's problems with peripheral conversion, the natural inclination of the physiology is for the thyroid glands to say, hey, if that peripheral conversion is not awesome, I can still help out. I can make a bit more T3.
No, that makes sense. I think that so the answer, from a practical point of view, where do we want to keep a TSH? And so we need to treat the patient, not the TSH, number one.
Oh, I totally agree with that.
Okay, so that's right. Number one. So a patient has been diagnosed with hypothyroidism, and I have no doubt that patient has hypothyroidism. That patient is going to start on levothyroxine. Okay, the TSH, let's say it was 20. I'm going to start giving levothyroxine. The TSH is going to come down. Let's say during a visit, TSH is 3.5. So I'm going to ask, how do you feel? Patient said, I feel fine. I'm so much better. I'm perfect. Blah, 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 blah. Okay, go home. There's nothing else to be done with this patient. Because even though the TSH is 3.5, meaning that it's not 1 where people like to have, I'm not going to bring TSH to 1. That patient is TSH is normal. Patient is fine. Go home. If you have any problem, come back in a year. Come back in 6 months with a new TSH, a new free T4. Now, same patient, a different patient, same TSH level, same story, 3.5. The patient said, I'm better, but my skin is still dry. I'm still unfocused. I can't put off the weight. I don't feel well. That patient, we're going to increase the dose of levothyroxine to bring it down closer to 1. The rationale is that patient remains hypothyroid. There's still residual symptoms of hypothyroidism that we could resolve by giving a little bit more thyroid hormone. Now, it makes perfect sense. It's many times the patient comes back and says, oh, I feel so much better. Because what you do is, please take half a tablet more on Sunday, once a week. And then the TSH is going to come down to 2, 1.5, or 1. And the patient say, I feel so much better. Other patients will say, it made no difference. So what do the clinical trial says? And in this case, there was a clinical trial. And there's no difference. When you bring the patient from a TSH of 3.5 to 1, in a randomized, double-blind, placebo-controlled, whatever trial, there's no difference. So the patient cannot tell the difference between the TSH of 3.5 and 1.5. The experience we have in the office is that some patients can tell, some patients cannot. Is this a placebo effect? Just because now the patient knows that it's taking a stronger dose, it's taking a greater dose, a larger dose, patient feels better? I don't know. I think we have 1 or 2 trials that were done, and they tell very clearly that the patients cannot tell the difference where they were. it's a TSH of 3.5 and 1. But makes sense to bring it down to 1 if the patient is symptomatic.
And if they're at a 3.5 and they feel good, and this is what happens a bit, is they feel good at 3.5. And again, I wouldn't look at just a TSH and T4. I'd be looking at the rest of the panel, all the labs. But traditionally, the traditional thing is look at a TSH and free T4.
I'm giving you the traditional view, yes.
But that patient who they go in, they feel pretty good at a 3.5, and their doctor says TSH 3.5 is too high. We want it lower.
It's not too high.
I agree, but they get put on the medication and they get it down into that therapeutic range, and the patient says, but I feel worse now. Can you explain why they might actually feel a little bit worse?
Right. But are you talking about the patient that had a TSH of 20 to start with, and then we brought it to 3.5, or a patient that was diagnosed with hypothyroidism with 3.5? Because
so this is a person who's been already diagnosed as hypothyroidism. They've had it tighter down.
Okay.
Now they found because this is the roller coaster ride that a lot of people go on. They're hey, when I'm at the TSH that my doctor likes, I don't feel good. And when I'm maybe sometimes a bit higher, I actually feel a little bit better. Somebody might be having a hard time. Like, my doctor says I need it to be lower, but when I'm there, I don't feel good. But I don't feel as good. When it's a little bit higher, I feel better.
I understand.
What's the potential reason why that might be?
I mean, it's hard to tell. I mean, I understand what you're saying. I have to say it makes perfect sense. What is that you said? Yeah, the patient has a residual thyroid there that could be producing some T3, producing some T4. The TSH is high. It's hanging in there. And when you start with levothyroxine, you mess up this compensation that's happening, right? Now you shut down TSH, you're just giving T4, and the thyroid production of T3 is going to disappear because you're suppressing the TSH. That is the rationale you're saying.
Mm-hmm.
I think it makes sense. This hasn't been proved in a clinical trial. I mean, let's have a clinical trial. To be able to accept it, we have to have a clinical trial saying, yes, if I bring the TSH from 5.5 or from 6 to 1, in patients that have a residual thyroid gland, they actually feel worse. This trial has not been done.
Yeah. Is it possible that the amount of T4 that you're providing to get that TSH down into 1 or 2 is sufficient to cause more D2 ubiquination in the periphery,
for sure,
and that's why they feel worse because their T3 production is going down?
As I said, what you said makes perfect sense. I mean, there's scientific basis to support that. We don't have a clinical trial.
Yeah. So because we see, I mean, I see that in practice all the time. But again, to make these big decisions, the clinical trial is where we say, okay, we've taken X amount of people. The problem is we assume that we've got X amount of people that, because they have primary hypothyroidism, that all the other things are the same. The only problem is that they've got primary hypothyroidism, but we don't know their life circumstances. Right. We don't know their diet. We don't know their systemic inflammation level and all these other things that could potentially have an influence.
Yeah. So, but I just want to say that it is the need for having a clinical trial is both a curse and a blessing.
Mm-hmm.
Why? Because if you are working with an assumption that is correct, and then you don't want to change that assumption, because to change it you need a clinical trial, you're good because your assumption was correct to start with. Mm-hmm. If someone challenges, you're doing a good job. However, if you're working with an assumption that's wrong,
mm-hmm.
and someone challenges that assumption, say, well, you have to do a clinical trial to prove that I'm wrong. And to do the clinical trial, you need $20 million.
Right.
And that's not going to happen. You keep doing the wrong thing until there's a clinical trial shown, because your thing doesn't have a clinical trial. I think that's critical for your listeners. Levothyroxine has been approved as the standard of care for hypothyroidism without a clinical trial.
Mm-hmm.
So we don't have a clinical trial. The FDA never required a clinical trial to show that levothyroxine alone was effective in the treatment of hypothyroidism. So that is important. It was approved because it was a drug that existed before the FDA was created. It was grandfathered in. So was there a standard of care? Yes. The standard of care at that time was desiccated thyroid extract. So the FDA could have said, you know, we have a standard of care, which is desiccated thyroid extract. Now, this pharmaceutical company came up with this new synthetic levothyroxine. Okay, let's do a clinical trial to prove that levothyroxine is superior to desiccated thyroid extract. That has never been done. Levothyroxine remained or was elevated to being the standard of care without a clinical trial. No, everyone that challenges the effectiveness of levothyroxine for everybody, like me, I think levothyroxine works wonders for most patients, but not for all patients. But if this challenge now needs to be backed up by a clinical trial. You see, I have to come up with a clinical trial to prove that what's being done is incomplete.
Right.
And I think that that's a catch-22, because that if you're doing the right thing, that's great to have a clinical trial to negate that. But if you're doing something that's not completely right, you protect yourself because you don't have a clinical trial.
Right.
You know what I mean?
I totally get it. And so that's why it's hard to make the change. And
very frustrating. Yes, exactly.
And if you're following the guidelines, I think this is where things get, I think, frustrating for the patient who's not seeing success in a T4 only model, is that they're like, why isn't somebody even consider doing something different, or why wouldn't they run those other tests? And I came from medicine, so I was angry in the beginning, but then I was like, listen, physicians are doing what they're taught. They're doing what the guidelines recommend.
Exactly.
And so why are they, because people will get frustrated. Why aren't they running T3? Why aren't they running free T3? Why aren't they running? Because if your job is to diagnose when the gland is fully exhausted and T4 is required, then you only need TSH
and free T4.
And free T4. And so why wouldn't they do more? What as we talked about before, if T3 is low, what are we going to do? If T3 is not the standard of care and it's not written up in the guidelines, then why would I run it? Right.
And although it makes sense to have it in the guidelines, you need to have a clinical trial showing that it's useful.
Right.
And to have the clinical trial, you need to have between $10 and $20 million.
Yeah. So I got like 2 more hours of stuff, but you've got stuff and I got another podcast right after this. So I want to, for the person who's listening, from a general perspective, where's your headspace when somebody's needs thyroid care? What are the general guidelines that you think about as the physician / researcher? If you're still working with clients, what's your headspace? T4, T3, T4, T3 combination? Or is it, as I think, it's not that simple? We have to take each individual client, assess their health history, their health timeline. We look at a full thyroid panel, we look at the rest of their labs, and then we make the best decision for the individual. But that's my opinion. Where's your space on this?
No, I would agree with you. Each individual is a different person. This is something it's very clear to me. We need to customize the treatment for patients. Now, you have to start with something to customize treatment, right? I mean, where do you start? I think that for a patient that has been diagnosed with hypothyroidism today, I would still start with levothyroxine for sure. Levothyroxine resolves the problems of 80% of the patients. You know, we have millions of patients with hypothyroidism in this country. 80%, it's hard to tell the number. The vast majority of these patients, they don't feel anything. They're fine. They're taking levothyroxine. The TSH is normal. The body has the ability to compensate for the shortcomings of the treatment with levothyroxine that we know exist. So now, if the patient comes back, normal TSH, still symptomatic, and those patients exist, we figure that it's anywhere between 10 and 20% of all these patients. So it still are, 2 to 3, 4 million patients in the US that might have a normal TSH and still be symptomatic. The only thing we can do is to look for other reasons for them being symptomatic. Sometimes a frequent confounding factor is menopause. A woman is getting close to the perimenopause, menopausal syndrome. The symptoms of menopause are very similar to the symptoms of residual hypothyroidism. So you have to start looking for that. Maybe the patient has another disease, maybe developed diabetes, maybe another autoimmune disease. I mean, there's got to be other reasons. Now, you go down the list and you don't find any other reason. Basically, you excluded everything that you could possibly think. You say, well, this is a failure of levothyroxine to normalize thyroid hormone signaling in this patient. The only thing we can do is to give some T3. So what you're going to do is you're going to reduce slightly the dose of levothyroxine, and you introduce a little bit of T3. We're not talking about going berserk with T3. We're talking about a few micrograms, 5, 7.5, perhaps 10 micrograms, depending on the size of the patient. But we're not, because I see patients that come taking 100, 200, 500 micrograms of liothyronine or T3. This is nuts. I mean, this is not a good idea. A good idea is to reduce the dose of levothyroxine, introduce a little bit of liothyronine, and maintain a normal TSH. So what you're doing is you're trying to mimic what the thyroid was doing. You just lower T4, give a little bit of T3, and then make adjustments in this ratio of T4 to T3 until the patient feels better.
And I think that's where we get sometimes in trouble, because sometimes that makes sense. In my world, what we see, and this is my 30 years of doing this, is I think the difference between what maybe I do and you do, and I don't know your practice and how you work, but when people come to me, they've already done T4 and they've done T3 and they just don't feel well. So I don't focus as much on I don't focus at all really on trying to manipulate the dose so much. My focus is on what's potentially triggering the inflammatory cascade, what's triggering the deactivation. So we look at lifestyle factors and dietary changes. And I think as I've been doing this for 30 years, what we see for the person, I really don't care what medication makes, if something makes you feel good and everything's normalized, that's great. But for the person who's really struggling, whether it's T4, T3, my suggestion to most of those people is, we've got to try and address what are the stressors that are causing the physiology to potentially downregulate metabolism. And when we do that, and I've seen this consistently over 30 years, that not only do they need less thyroid hormone medication in most cases, their conversion of T4 to T3 gets better, their cellular physiology gets better, their metabolism gets better. And that's where I think there's sometimes the disconnect and the frustration, not necessarily about allopathic medicine or integrated medicine, but we've got to be careful that we're not saying, hey, allopathic medicine is bad because they only do T4, and we're better because we just start giving. Sometimes it's beneficial, especially if the gland's destroyed, to have some T3 in the system. But I don't think that just, hey, if a little T3 is good, lots is better. I think that's a problematic strategy. And as you said, that's what can create a lot of issues. So I know we got like a minute left, so I want to talk to everybody. You've got a book out. It's called Rethinking Hypothyroidism. I've got it all highlighted up. Tell people a little bit about the book, and then where they can get the book and what they might learn from the book.
Well, I think the book, first of all, tells the story of this crisis that we live right now. Because if you ask doctors, well, hypothyroidism is the simplest disease in the world to treat, and patients don't necessarily think that. So there's a disconnect. And I start by saying that there is a disconnect that we doctors, academic doctors, need to recognize that there's a major disconnect in a lot of patients that are unhappy. So that's number one thing. Number two, I tell the strong influence that pharmaceutical companies had in this process, in creating this idea, influencing physicians to, accelerating the use of the acceptance of levothyroxine as the standard of care for treatment of hypothyroidism. And then I talk about these guidelines and how the guidelines are prepared, how are they written, what the story, a little bit of the guidelines, how they changed over time, how American guidelines are different than European guidelines. And we're trying now to have a consensus and create something that's uniform around the globe. And then, so in each one of these points, there's always a different views between doctors and patients. And I think I try to explain how that was created by talking about the history of hypothyroidism. So there's a lot of history, starting from 1800s until the current day. What happened? How was treatment of hypothyroidism? Most people don't know that desiccated thyroid extract was the standard of care for treatment of hypothyroidism longer than levothyroxine.
Long before
has been the standard of care. And so I think that knowing that history is a good thing. And then I talk about this shortcomings of therapy with levothyroxine and what patients can do to work with their doctors to overcome this. The book is written in a very simple format. Is not for doctors, is for patients and for doctors. So I try to be careful and explain everything in a way that doctors would understand and patients would. So doctors wouldn't find boring because it's so trivial, the language. No, I thought I did. I tried to create a mystery around the thing, so it goes back and forth, telling all the mechanisms. And I think that I have received very good feedback from patients and from doctors. And you can buy the book anywhere. It's pretty cheap, and you can get on Amazon, on any bookstore.
And if people want to learn more about some of the work and research you're doing, where's the best place that they can go to?
I have a website that it's biancolab.org or deiodinase.org. It's the same website. I have a Twitter account, which is at Bianco Lab. I think that every time I publish something, I try to put on Twitter. This is actually the NIH, prompt you to do that. So bring your research to the public so people know what the NIH dollars are doing. I have a Facebook page. I try to put, but whatever I think it's of interest for the public, I would put there. And, don't feel embarrassed to send me an email. I get emails from patients every day. If I can answer, I will. If I just don't know the answer, I'll tell you up front. But I'm easily reachable person.
And I'll attest to that because he got right back to me. So
right, exactly.
I want to thank you for your time and the conversation. I could talk to you for a couple more hours.
Yeah.
So maybe we'll get you on a future podcast.
Absolutely.
And have a discussion. Yeah. Okay.
Thank you very much for having me. It was a great pleasure.
Thank you.